heart disease from my publication on this is sandwiched beautifully between the talk that Dr. Merrill Cohen gave on AV septal defects some weeks ago and the talk next month that Professor Anderson is delivering with his colleagues, pathological and embryological colleagues, on AV septal defects. So today we are going to look at this, and I'd like to acknowledge Professor Bob Anderson, who provided me with a substantial amount of guidance and morphology, Dr. Diane Spicer, whose pictures are of the greatest and highest quality and has provided me with a substantial amount of information, and my colleague from the University of California in San Francisco, Dr. Philip Ursell, who provided me as a archivist of this collection with the permission to use the UC archive. So I'm going to start talking about AV septal defects and its morphology. And here is a simulated subcostal cut of an echocardiogram showing the position of the right and left ventricles and the aortic root wedged beautifully between the tricuspid and the mitral valves. The septal, inferior, and anterosuperior leaflet of the tricuspid valve are evident, and the papillary muscles supporting the anterior or aortic leaflet of the mitral valve and the mural leaflet are clearly shown. Note that the depth of the anterior leaflet is large compared to the depth of the mural leaflet, but the circumference of the mural leaflets occupies 2/3 of the circumference. So we always say the anterior leaflet has 2/3 of the depth and 1/3 of the circumference, and the mural leaflet has 2/3 of the circumference, but only 1/3 of the depth. Now, what happens in AV septal defect? And here is a complete AV septal defect, sliced in the same way as you see it here, showing the complete AV septal defect with the anterior superior leaflet, the anterior superior leaflet of the tricuspid, the mural leaflet, and the inferior leaflet. Note that the leaflets are superior and inferior rather than anterior and posterior. And here is the superolateral and the inframedial papillary muscles supporting, I beg your pardon, there's the inferior papillary muscle, supporting this valve leaflet. And as opposed to the normal heart that you see here, where the circumference of the mural leaflet is 2/3, this can be very small, and the papillary muscles are rotated around and may be close together and become, in fact, even a single papillary muscle. So there's the complete atrioventricular orifice. The aorta is sprung out of this area. It cannot settle in here because of the position of the canal. So this is the feature, one of the features of the AV septal defect. A common AV junction, okay, and an unsprung, the aorta is not settled into the AV orifice and is out of the AV orifice. Now, for those of you who are looking at this on a smartphone, I've zoomed these up at the end so that you can get this. Now, let's just look at that in regards to embryology. And here is a picture from Dr. Netter's atlas, written in 1955. And you see here the lateral leaflets, the superior and inferior bridging leaflet, and this AV valve, the common AV valve, straddling at this stage of embryology between the right and the left ventricle, so that there is two sides open here. And here is the area of the conus where the spiraling of the conus occurs. And here, of course, the left ventricular outflow tract cannot get into the orifice. And so here we look at the echocardiographic equivalent of what we see on morphology. And this, in fact, is the fundamental of this particular session, is the echo-morphological correlations. And so here's the morphology, and here is the echo, which is pretty much the same. And when we take the valve leaflets again, you can see the superior bridging leaflet is attached to the crest of the septum. The inferior bridging leaflet is attached to the crest of the septum, and the lateral leaflets and the anterior-superior leaflets on both sides make up the rest of the AV septal defect as we now know it. And of course, this comes from courtesy of Professor Anderson, but it's a work of Dr. Tim Mohan, and this is an example of a E10, 10.5 day embryo, and here you can see the loop, and this is the left ventricle, and here the AV canal is entirely related to the left ventricle, and this then would be the primary interventricular foramen, and here you can see already the spiraling of the septum dividing the truncus and conus into two sections. And if we cut this in a 4-chamber view, we would see again that here is the AV septal defect a little later here, which is now moved over so that there is a communication from the right and the left atrium into this ventricle. And this is then becomes the secondary interventricular foramen. And here are the developing right and left ventricles. Now, what's the concept by echo? Well, there's the whole series of issues that occur in here. First of all, we can get the defect that we know as the ostium primum, or the primary atrial septal defect, where the AV valves fuse to the ventricular septum, allowing only an interatrial communication. Rarely, and here is an echocardiogram showing, morphology showing this. So here you can see that the valve is across, has fused, and there's a right and a left orifice, and here is the lower part of the septum primum, which has not made contact with this, leaving an ostium primum or a primary atrial septal defect. Very rarely, the atrial septum fuses with the AV junction, leaving only a ventricular shunt. So here you can see even no foramen ovale here. And here is a ventricular communication, which is straddled by the AV valve as it comes across it. And the most common one is the complete AV septal defect, where we have as well a ostium secundum defect, or a secondary oval fossa here, which is fenestrated, a primary oval fossa defect here, and also a common AV junction which allows straddling between the right and the left ventricles at the ventricular level. So those are the three options that we have, and I'll just take the labels off so that you can see those three options very clearly identified. And here is the superior bridging leaflet straddling from the left ventricle into the right ventricle, and here is the posterior leaflet, which has already begun a little extension towards the superior bridging leaflet, but has left a bare area between the right and the left ventricles here, and a straddling of the valve from left ventricular papillary muscles into right ventricular papillary muscles. So because of this issue, there is a change in morphology between the normal heart and the heart with an AV septal defect. And here we've got 4-chamber cuts of a normal heart showing the long length of the posterior interventricular septum with the fusion of the atrioventricular valves to the junction here with the normal offsetting. And here on the right, we can see what happens in an AV septal defect. So because the canal doesn't develop completely and is fused in this stage, the inlet septum is small. Compare the normal heart to the heart with an AV septal defect. This is the posterior or inferior leaflet, which is always attached to the crest of the septum. And I'll take the labels off so that you can see those two different issues here. And here on the echocardiogram, you can see that same feature of the small septum leading to what we'll show in a few moments as a disproportion between the inlet and the outlet ventricular septum. Okay, so here is a perfect correlation looking at the posterior leaflet with its caudal attachment to the crest of the septum. Now, if we look from above, we have a little problem. Here is the echo scan. And here we look from above. This is the right side, and this is the left side. So here is the mural leaflet, the superior bridging leaflet, the bare area of the ventricular septum, the inferior bridging leaflet. The inferior and anterior superior leaflets are what will become the tricuspid valve. And here you can see that the aortic root, or the great vessel root, is sprung out of the strap here. It is no longer contained in here. So now let's just look at this. Here's the superior bridging leaflet and the inferior bridging leaflet and the other components of the valve and the bare area of the septum. Now we can do this echocardiographically, and we are looking at this here in a subcostal cut. But because we're looking at this from above and this from below, they are reversed. So the right side is on this side here, and the left ventricular side is on that side there. So now I'll just take those labels off for you. And now you can see the superior bridging leaflet, the inferior bridging leaflet, the mural leaflet, the papillary muscles, very important thing to look at, and the inferior and anterosuperior leaflets that make up the rest of the common AV valve. And you can see that this valve is attached to the crest of the septum, the anterior leaflet in this case. Excuse me. Now, who was responsible for all this was Dr. Giancarlo Rastelli, and this is Dr. Giancarlo Rastelli, who died, unfortunately, before he became a great surgeon, because he had lymphoma and died at the Mayo Clinic. And here you can see the cartoons of the canal that he called the Rastelli type A, where there was a small degree of bridging of this leaflet and a fairly large anterosuperior leaflet. Here's the leaflet then attached to the crest of the septum. The posterior leaflet is always attached to the crest of the septum, and the papillary muscles are narrowly spaced, with this being the small mural leaflet that I've talked about. So here's the anterior superior leaflet with the anterior papillary muscle, and there's a complete AV orifice. Now, the next variety, which you see, is a type B, which is very rare. So I'm going to go into the other major type, which is a Rastelli type C, where here the anterior bridging leaflet, or the superior bridging leaflet, straddles across the ventricular septum but does not attach to it, and then the anterosuperior leaflet is attenuated. So these are the Rastelli type A and Rastelli type C examples that you see here. And because the papillary muscles support commissures and the valve leaflet is attached across the ventricular septum, it leaves a commissure which we call the cleft in the so-called mitral valve. And here is an example of a patient with the normal papillary muscles and one where there is a so-called cleft in the mitral valve with attachment to the crest of the septum. And you see the papillary muscles are rotated round from this position to that position over there, which is typical here. Now, in an isolated cleft, as we see over here, the papillary muscles are normal, the mural leaflet is large. In an AV septal defect, the papillary muscles are rotated round and the mural leaflet is small. And here is an echocardiographic example of an isolated so-called cleft in the mitral valve, which is nothing other than the analogue of that primitive commissure that was present here. And on the right side, we see again the rotation of the papillary muscles, the close spacing of the papillary muscles, and the caudal attachment to the crest of the septum. So that is talking about the clefts. Now, we talked about why the aortic root is not in its normal position. Here is a normal heart, and here is the measurement of the outlet septum and the inlet septum. And you can see that they are the same length. Whereas when you look at the left ventricle in an AV septal defect, you can see that the inlet septum is shortened, and the outlet septum is actually elongated because the aortic root cannot get into the junction between the two valves. And this led to the angiographic expression of this being a gooseneck deformity. And so here we can see the comparison between the normal and the AV septal defect. And there you see the bridging leaflets, superior and inferior bridging leaflets. And here you can see on the echo, beg your pardon, on the angiogram, there's the echo, the so-called gooseneck deformity related to the abnormal position of the AV junction. And on the angiogram, this is a finding described by Murray Barron in 1964 of the so-called gooseneck deformity. So I've cartooned the gooseneck deformity over this AV septal defect, and you can see, I'll take the gooseneck off now, and I will show you, there's the gooseneck deformity because the valve is in an abnormal position. Here's the complete AV valve, and you can see a regurgitation through the commissure into the right atrium here. And here is the echocardiographic example of this gooseneck deformity. So here are two specimens showing this. This is actually an ostium primum ASD where the valves have been removed and shows this extension of the left ventricular outflow tract to the aortic valve, the so-called elongation that leads to this outlet-inlet disproportion. And the inlet, of course, is narrowed. So this is really very easy to see on the cartoon and can also be identified here on the echocardiogram, showing this abnormality of the outflow tract that leads rise to the gooseneck deformity. Now we're looking at the AV valve at the junction, and this is a patient who's got fused AV orifices. Here is the superior bridging leaflet, here is the inferior bridging leaflet, and you can see that this leaflet is tricuspid with the superior and inferior and the mural leaflet making three components of the valve. And you can see the superior leaflet is elongated, the inferior leaflet circumference is attenuated, and that the mural of the inferior leaflet has actually grown forward and fused with the superior bridging component, leaving a so-called cleft in the valve leaflet, but with a divided orifice, both a right and a left ventricular orifice. And here I've turned the echocardiogram round for you. That's the left component and the right component. Left component, right component up here. There's the right component there. Here's the left component. There's the septal attachment there. This may be foreign for you to look at because I deliberately made it backwards. You can see the ECG is running backwards. So we'll turn that round just to let you look at the comparison between the commissural attachment there. And then we'll turn this around to look as we normally look at an echocardiogram. And you can see here the commissure attached to the septum looking towards the right ventricle with the superior and inferior bridging anlagen, as well as the mural leaflet of this valve of a so-called primary atrial septal defect. So now we look at the AV septal defect from the point of the view of the atrial component. And here is the oval fossa. This is the right atrial view. Here's the right ventricular view. This is a so-called Rastelli view. And here is the lower rim of this primary septum. And here is the inferior bridging leaflet, which is extended forward and is attached to the superior bridging leaflet, dividing the orifice into a right and a left component. It is very important for me to enforce with you that although there are two orifices, there is really only a solitary annulus for this valve, which lies across the whole ventricle, and that is regardless of the time of defect. And here you can see at this heart that the atrial septum is perfectly formed. Here's the foramen ovale. Here's the rest of the atrial septum. There's the coronary sinus with the Thebesian valve, and the Eustachian valve is over here. And this atrial septum is perfectly formed. What it has not done is it has not fused with this leaflet as it would in the normal circumstance. And this is really the fundamental of the defect, is that it is not an interatrial defect, but it's a defect of the failure of fusion between the primary septum and the underlying AV valves. So here is an ostium primum ASD, as we well know. And I've shown you this with the fact that there is a large amount of flow coming across here. There is central AV valve regurg coming all across this valve. And because of the flow in this direction, the jet is directed from the left ventricle into the right atrium. So there's the primary defect. The valve is attached to the crest of the septum, so there's no ventricular shunting in this patient. And this is then what we call the ostium primum, or the incomplete AV septal defect. Now, when we look at the regurgitation, it's very interesting because this is one of the important aspects of what an echocardiographer can do in terms of helping the surgeon to understand where the valve is deficient. And here you see a big atrial shunt, and because of the process known as, gosh, I can't remember the name now, entrainment, that's the name. The flow across the atrial septum is going in this direction, and it takes this jet, which was coming up in this direction, and directs it from the left atrium into the right atrium. So that gives rise to a left ventricular right atrial shunt, which is a characteristic of AV septal defects, and which we saw also in the complete AV septal defect angiogram I showed you earlier. And here's a patient who's got three jets, one from the commissural jet almost centrally on the left side, and two jets through the right component of the AV canal. But because of the shunting that occurs at atrial level, the three of them are all moved to the atrium, and these jets actually entrain each other into a common jet in the end run. And here's a patient with pulmonary hypertension. You can see a very large right side here. The shunting is going in this direction at atrial level, and the jet then is going from the central area into the left atrium. So entrainment is important physical phenomenon, and it also explains the direction of some of the jets that we see on the echocardiogram. And here is just another example of a jet. This one is coming through the commissure, and this one is coming through the coaptation of the superior and inferior bridging leaflets. So we can look at that, and we can see where those jets are coming and from which components they're coming from. This is clearly coming through the commissure, and these are really coming through at the junction of the leaflets, the leaflets together, and maybe coming at the junction of the inferior bridging leaflet with the mural leaflet as well. And just to remind you that, of course, the superior look can be obtained by color flow. This is courtesy of Dr. Cohen from her wonderful presentation. And you can see here this jet skirting the back of the atrial wall and hugging the atrial wall here. And this is the right side of this jet. So we've seen ostium primum ASDs, very simple, easy to recognize. We have to, of course, enforce that the valve leaflets, that there's no ventricular component, and the valve leaflets are on the same level. Sometimes there is minor fusion, in which case there would be a little interventricular communication, and we would then call this a transitional form of AV septal defect, which I will show you momentarily. But here is the subcostal equivalent, showing this very beautifully and showing the large pulmonary veins with the shunt coming across at atrial level, left to right, with a small degree of central AV septal defect regurgitation. Now, when you see something like this, the surgeon probably has to do an annuloplasty if he wants to get rid of this. Of course, what is important is how much there is after he's come off bypass, and it may not be worthwhile to go and do an annuloplasty in this event, but that can only be determined after with transesophageal echo after surgery. Now, here's another primary atrial septal defect. You see the lower crest of the atrial septum here with a normal atrial septum, so this hasn't fused to here. Here's the superior bridging leaflet anlagen. Here's the inferior bridging leaflet anlagen, which is extended forward and grown and fused with this, leaving a right and a left orifice, albeit still with a common atrioventricular junction. And here is such an example here. And I put this one on because you must always look at all parts of the heart, but I'll show you this when we take the label off, that there's a little cortiratriatum membrane here in the atrium with the acceleration of flow beginning at the place where the cortiratriatum membrane is seen. And I'll take the labels off so that you can look at that and see this little remnant of a cortiratriatum here. This is a pre-operative image which was confirmed at the time of surgery. So now we'll talk about those that are ostium primum ASDs, but with ventricular components. And here you see the valve leaflets are fused. So now we've got the oval fossa over here, the ostium primum atrial septum, and the fused superior and inferior bridging leaflets with a fairly substantial AV septal defect here. So two orifices with one common junction. And here is an echocardiogram that corresponds to this and shows the interventricular communication, which looks small. It looks small because it's more cigar-shaped than it is a true circular orifice. So here's the ostium primum defect with the atrial component, and there's the ventricular component down there. Ventricular component, atrial component. Often when this valve leaflet is fused, here's the inferior bridging leaflet with this extension fused to the superior bridging leaflet. This area becomes redundant and bulges into the right atrium. You can't see it on the specimen. We just call this the connecting tongue of tissue over here. Here's the lower rim of the primary septum. And here you can see this leaflet bridging and attached over here with no ventricular component to it. And that this is commonly a feature of the transitional form of canal, which the Japanese in 1984 called a tricuspid pouch lesion. So you see this area billows out in dynamic fashion and creates what looks almost like an aneurysm of the membranous septum, but it clearly is an AV septal defect. Now let's look at what Rastelli did in terms of his classification. This is, I think, more of a historical than actual importance, because the surgeons have really established what Rastelli had told them about fixing a canal and can do it. But what Rastelli said was that the posterior leaflet, the inferior bridging leaflet that you see here, is always attached to the crest of the septum, as marked by the arrow, whereas the anterior leaflet may be attached to the septum, may be attached to a right ventricular papillary muscle, or straddle completely across that. And he called this A, that B, and this one C. So let's look at a Rastelli type A on the echocardiogram. And of course, it can be very difficult because what you have to do is make sure you're looking at the anterior leaflet. So we're looking at the superior bridging leaflet. I'm going to take that off, and I'm going to stop this here. And I'm going to show you, as I move this, what this example shows. This is a sweep. Okay, there's the posterior leaflet attached to the crest of the septum. Okay, we're almost back at the coronary sinus here. So we're looking way back at the posterior aspect of that valve leaflet. Okay, and then we move forward towards the aortic root. And as we come into the aortic root, we're now looking at the anterior leaflet, and you'll see this anterior leaflet is attached to the crest of the septum there. There's the tendinous cords attached to the crest of the septum. So this is the anterior leaflet. It's not a very easy thing to see and has given people a lot of problems. But you can clearly see that this anterior leaflet, when you see the aorta, is attached to the crest of the septum. So this is a Rastelli type A lesion. And there I'll show you very beautifully the attachment of this anterior superior bridging leaflet. At the time we're seeing the aortic leaflet of the valve, making this a Rastelli type A. Now, this is a very rare example of a Rastelli type B. The echocardiogram is of this heart which has been bisected in the 4-chamber cut. So we'll take the echo plane off, and here you can see the ventricular septum, the right atrium, the inferior cava, the ostium secundum defect, ostium primum defect, and here is the right atrium, the left atrium of the front of the heart, and here is this papillary muscle which is attached to the crest of the septum over here, giving rise to what we call a Rastelli type B example. And that's a beautiful example. It's very rare. I circularized a number of people to provide me with a better example, but this is the only one I could come up with in my collection of a Rastelli type B, very uncommon. If anybody has one of the audience that is listening, I would be delighted if you would be able to send me that such an example in a 4-chamber view, so I can improve the quality of my picture. But clearly this is a attachment to a papillary muscle, not on the crest of the septum, but on the right ventricular wall. There you go. All right, so there's the papillary muscle. And for those of you on your iPhones, there you go. Now, this is a beautiful example from Diane Spicer's collection of a Rastelli type C. And here I think you can see in the 4-chamber view that when you look at the posterior leaflet, here's the inferior, beg your pardon, leaflet. Here's right atrium, left atrium, secundum, primum defect, and you can't see the VSD here because the valve leaflet is tethered to the crest of the septum. So this is the inferior leaflet tethered to the crest of the septum. And that was what Rastelli said, is that the inferior leaflet is almost always attached to the crest of the septum. Now here is the front half of the specimen. So this is now the left atrium, and this is the right atrium with the right atrial appendage. There's the secundum defect. Here's the primum defect here. And here is this large interventricular communication. But you see the anterior leaflet is straddling between the left ventricle and the right, I beg your pardon, between the right ventricle and the left ventricle. Okay, there is no attachment of this to the crest of the septum. And it makes some difference to the surgeon into how he fixes or she fixes this particular disease. And here is an echocardiogram. And now we're going to look just at the anterior leaflet of this valve leaflet as it moves. and you see the valve leaflet strikes the septum in systole but has no attachment, and the attachments are from the right ventricle across the septum and into the left ventricle, with a huge interventricular communication here. And one of the features that surgeons sometimes like with this disease is there's a lot more room to work when you have this type of lesion. Now, this lesion is interesting because it occurs more commonly when there's conotruncal defects. So in tetralogy, truncus, double outlet, and transposition, this is the usual form of this defect, whereas type A is probably more common lesion. So now if we look at short axis cuts, whether we look at them from the subcostal or the parasternal view, we can see this, and I've shown you this before. And here we see the superior bridging leaflet attached to the crest of the septum. Here is the anterior superior leaflet of the tricuspid valve with the papillary muscle. And here is the right ventricular orifice. Here is the inferior leaflet. Here is the bridging leaflet going across here. And here is the mural leaflet here between the very narrowly spaced papillary muscles. So you can see here in this that the superior leaflet occupies a much greater part of the circumference of the AV orifice than the mural leaflet, which we showed earlier on. And then here we see the same thing on the echo subcostal sagittal view. And here you see the papillary muscles, which you can identify beautifully. So there's the mural leaflet. Here's the anterior superior leaflet. And you can see this anterior superior leaflet here is attached to the crest of the septum. The inferior leaflet is likewise attached. And that makes very beautifully a type A AV septal defect. And you can see when you close this defect, I'll just stop it here for a moment. As I run this all over here, you see when the valve leaflet closes, it closes in a trifoliate fashion. There's the leaflet closed there. Okay. Let me let that play again. And I'll bring this up here. And yeah, I think in real time, you can see the papillary muscles making the closure of this trifoliate leaflet of the AV septal defect type A. Now, Rastelli type C, as I said, is more common when there's conotruncal defects. In fact, if you see a conotruncal defect and an AV septal defect, you can almost assume that it's a type C of Rastelli. And here you can see the bridging leaflet attaching between the right and the left ventricles. Looking from below, there's the primary septum crest over here, so the big ventricular communication across here. And you can see the valve orifices on both of these, which I've highlighted in red. And now I'll show you that with the orifice in red. Here's the overriding aorta in this tetralogy AV canal, almost certainly a Down syndrome baby. And there you see the anterior bridging leaflet is attached to nothing. It's attached to a papillary muscle lying within the right ventricle. So this is a Rastelli type C for what it's worth, and always important if you tell the surgeon what you expect him to be able to see. Now, I haven't mentioned 3D echo, but obviously 3D echo is very, very important. And one of the things that we've never been able to do with 2D echo is to be able to establish the extent of the interventricular communication. And if you look at this from the left side, so aorta is anterior here. There's the ventricular septal defect. Here are the leaflets, the inferior and superior bridging leaflet. You can't actually make up the attachment. There's the lower rim of septum primum. So this is the atrial component. But look, there's not a very big defect over here. But when you look at its extent, it's running from the back to the front of the heart. And the surgeons, when they do this repair, they take a silk thread and they place it across the ventricular septum to see the length of the patch that they must make, because they have to put the patch over the entire ventricular septal defect. So I think this gives a much needed and beautiful idea of the patch. And you can turn this echo around and slice it back on this taken from a full volume echo. And look, here's the pulmonary trunk up here with the aorta just over there. And here again, you can see that this defect runs the high length of the ventricular septum, and the height, of course, is much shorter. And here you can see again on this specimen, we can see what's going on here. I hope my power doesn't break on me. It says it's not working. Just give me 1 second to check why the power is not working on this specimen. Oh, it's come out. Yeah, where is it? Excuse me, 1 moment. I'll put it in and there'll be power and we'll be able to carry on with this presentation. Okay. Thank you. So, I've let you look at that, I'm sure, with ease. And now let's go on and let's look at other examples and problems with AV septal defects. This is from a fetus that died or was terminated. And this is the aorta and the pulmonary trunk. Here is the deviated outlet septum narrowing the right ventricular outflow tract. So this is tetralogy. And then there's a big AV septal defect here with the leaflet straddling from the left ventricle into the right ventricle and unattached to the septum. So this is an AV septal defect. With the valve leaflet is a common orifice over here. So this is a Rastelli type C. And when you look at these two leaflets, when you look at this, and it's if you focus on the outlet septum here, you see the classical features of tetralogy of Fallot, with the anterior superior deviated outlet septum and overriding aorta, overriding the ventricular septal defect. Here's the ostium primum ASD at the back, and this is the right component of the valve. And we turn this round in the other direction, and we look here, you see again the narrowed outflow tract here, and here is this component of the left AV valve, and I'll take the labels off, because you can see the valve leaflet straddling into the left ventricle, into the right ventricle. So here you go, you see this leaflet coming from here and straddling to attach to the papillary muscle way over the septum here. So this is then an AV septal defect with the so-called cleft in the valve. And I'll let that play. And I'll increase the size of this. And there you have the leaflet straddling across, but without attachment to the septum of the superior bridging leaflet. So tetralogy with AV septal defect. And here's an even more fascinating patient. Here is the position of the ventricular septal defect. Here is the superior bridging leaflet straddling across. And here is the double outlet from the right ventricle, with the ventricular septal defect being more committed to the pulmonary trunk here. And here is such an example, again showing type C of Rastelli and the double outlet from the right ventricle. Take the labels off and zoom it up for you so that you can get a good look at that. These pictures are from Diane Spicer. And then here is just the isolated ventricular component of the defect. And here you see the corollary sinus and the oval fossa. And here the atrial septum has fused with the AV junction. The only thing that's happened is that the area underneath that has not fused, and you have a ventricular component. Now, this is a difficult lesion because if you call this a membranous ventricular septal defect or a big inlet VSD, the surgeon wants to repair this as a VSD, whereas he has to really repair this as an AV septal defect. There's almost invariably a cleft mitral valve here, or a cleft in the left component of the AV valve, the so-called mitral valve. And here you see the tendinous cords attached to the crest of the septum. The normal left ventricle or normal mitral valve does not have caudal attachment to the crest of the septum. So there's the crest, the cleft in this valve. You see the AV valves on same level, so this is a defect that is extended into the inlet septum. And here you can see the tricuspid nature of this defect, and there is the caudal structure going towards the crest of the septum of the septal defect, as it almost invariably does. So this is a VSD of the AV canal type with a so-called cleft in the so-called mitral valve. And here's another example, because I think that this is something that often fools us. It's fooled me once, but not the second time. And here you can see the septum fused to the AV junction here. Here's the coronary sinus, there's the oval fossa, to pretty much closed defect, and the communication is below the level of the AV valves in the position of an AV septal defect. And here you see such an example here as well. Different example to show you that it's not just an isolated fluke. Now, the other issue here is we talked about the inlet-outlet disproportion. Inlet-outlet disproportion. Now, because the aortic root cannot extend into the ventricle embryologically, this area is elongated and may be narrowed, and it is always narrowed, giving rise to the so-called gooseneck in the AV septal defect. And here you can see how narrow is the outflow tract. Here's the aortic valve, and here's this narrowed outflow tract. And here's a fetus that developed a almost hyperplastic left heart, because there was no egress from this left ventricle. The egress was through the right ventricle and then retrograde flow around the ductus, just like a hyperplastic left heart. And the baby actually had a Norwood procedure because we couldn't remove this tethering at surgery. So here you see subaortic stenosis as a feature which can be really quite severe in some of these patients. And here is another example of an AV septal defect, this time from the Brompton collection. And here you can see the subaortic shelf. Here's the subaortic shelf here. Okay, so and this patient on the echo, you'll see the features of the tendinous cords attached to the crest of the septum. Here's the interventricular communication. Here's the narrow outflow tract, and here's the subaortic obstruction. So tendinous cords, subaortic shelf, and aortic valve, and this LV outflow tract narrowed by this tethering of the AV septal defect as well. So this is a parasternal long axis view, and I think you can see the cords, the fibrous tissue of the subaortic shelf, and the aortic valve above that. Now, other things can obstruct the LV outflow tract, and in fact, the valve may be, instead of being just a single valve, may have a double orifice with accessory tissue within the left ventricular outflow tract. Here's the left ventricular outflow tract. Here's this tissue here. Here is the cleft valve, which is attached to the crest of the septum of this AV septal defect. And this is really quite a beautiful echocardiographic examples. We have several of these in our collection. And here you can see this little secondary orifice here, very beautifully shown here. And this, of course, obstructs the outflow tract. Now, it's a very easy lesion to take care of. You have to come in through the aorta, open the valve leaflet, just grab this, and you just cut it off and tie it off, and then there's no leaf obstruction underneath there. So AV septal defect, there's the little diaphragm in this accessory valve leaflet with tendinous cords on it. And the tendinous cords are invariably attached to the crest of the septum which is what tethers this valve and makes it obstructive. The other issue about AV valves is the position of secondary orifices. Here is a double orifice mitral valve. And this is one of the lesions which is most frequently missed echocardiographically. The reasons it's missed is we always look for it down at the tips of the valve leaflet, whereas the double orifice is almost invariably at the AV junction here. And here is such an example of a double orifice valve with a dominant AV valve orifice here and a secondary orifice moving in and out of the plane here. I will take the labels off for you so that you can see that secondary orifice here going up and down and up and down. So remember to look for this at the base of the valve. There's a lot of missing of this lesion, and of course 3D echo would be a very good way of supplementing this. Now lastly, the septal papillary muscle, or the two papillary muscles, may go so close together that it may be a single papillary muscle, and then if you close the cleft in the valve, then you're dealing with a parachute mitral valve. So it's very important to look at the papillary muscles and make sure that they're in that region there. So here's a solitary papillary muscle. Look there. And of course, this left ventricle doesn't look like it's much. But if you close this over here, you've got a parachute mitral valve to deal with. And here is indeed a three-dimensional echo showing this common papillary muscle here, and the valve moving as a single papillary muscle with a valve here and with a cleft. And if you close the cleft, you're left with the parachute mitral valve. And here's a two-dimensional echo showing both leaflets attached to a common AV valve. So single papillary muscles are something to beware of in this condition. And lastly, we have to talk about this condition of whether there's balance of the AV canal, whether the right ventricle or the left ventricle is dominant. Well, the truth is, because of the left to right shunt that occurs, the right ventricle is usually a little bit dominant. But in this example here with the echo, you can see that the left ventricular wall is a sliver, and the echocardiogram is really not much more. The valve orifice is lying almost exclusively over the right ventricle. There's just a small amount here. And then here is the opposite situation where there's a left dominant AV septal defect. The valve annulus is largely over the left ventricle, okay? There's very little in the right ventricle, and the echo shows that very beautifully as well. And I'll take the labels off so that you can see that. So the one is an unbalanced, they're both unbalanced AV septal defects. This one is a right ventricle dominant, and this one a left dominant. And I think in both of these examples, these patients would have to go down the single ventricle route. Here's another beautiful example of a right dominant AV septal defect with a tiny amount of valve overriding the left component of the valve, maybe just a small papillary muscle with a sliver of the left ventricle there. And the echocardiogram shows the same. And here we can look at this from above, and we can see the difference between a right and a left dominant. This is the right dominant AV septal defect viewed from above. And here's the echo backwards. So this is the left ventricle, and this is the right ventricle, left ventricle and right ventricle. And we'll turn this around so that it looks like an echocardiogram. And now we can see that the right side is really dominant over the left side, and there may be only a solitary papillary muscle here, also forcing this patient down the single ventricle route. And here another example of a left dominant AV septal defect, pathological. Here's the left ventricle, here's the right ventricle, here's a 4-chamber cut. Again, a small amount over a sliver of right ventricle, okay? And when we look at this in the subcostal cut, there you see the position of the septum here, with the valve overriding dominantly the left ventricle component with a small component in the right ventricle. And I put the dots in to show you where the septum is. I'll take that away and let you look at that. And so in conclusion, what we've talked about pathological echocardiographic correlations. And we're seeing the common atrioventricular junction as a uniform feature of AV septal defects. The aortic root is sprung because the root cannot settle into its normal position, leading to inlet-outlet disproportion of the septum, narrowing the left ventricular outflow tract. Because the AV valve doesn't develop, the papillary muscles are swiveled, and the smaller than normal left mural leaflet of the aortic valve of the mitral valve, of the left AV valve is also identified. Sorry for that little typo. So that's it, ladies and gentlemen, and I'm happy to try and answer questions for you if there are any.
Thanks, Norman. If you want to open your video.
I'm trying.
Yes.
Okay. So now.
Now we open.
Okay, open. Okay.
Okay, very good. So we see if we have some question by.
I'm looking. I've said no open questions.
Yes. Yeah.
Well, do you have any questions, Sasha? Did I make any points that you want to augment?
Yes, but I think that every time you, and as you say, together with Meryl, are able to share echo view, anatomic view, and the main consideration about the view of the heart in different approach, I think it's something that's amazing for all the people. I have a question. If you consider still the classification or your experience, there is some word of difference or some different idea about Rastelli classification, because surgically sometimes very few cases are not well, described by A or B or C. I want to know if in your huge experience is still a milestone, or there is some case where we can think different.
Well, look, I think that what I think the Rastelli classification, it really does make it easy to understand how the valve is working, because embryologically, the Rastelli type C is the primitive one, B is less primitive, and A is the most mature. And I think that allows us to make an understanding of what the Rastelli classification is. Now, you as a surgeon have been very kind, because I know when you go in there, you look at the valve, you see the valve, you lift the valve up, you do all kinds of evaluations on the valve. I think we give you a better example of the Rastelli classification with the 2D. Then often you can identify in there, but what we show you is the tethering of the cords. Now, I think that my feeling about my association with surgeons is that if you tell the surgeon what he's got, and he actually finds it, or she finds it, then they actually trust you more about other observations that you've made. So I think that telling people about the Rastelli classification is a trust more than anything else. And I think when an echocardiographer and a surgeon develop a trust and an understanding, that the surgeon probably sleeps better the night before the surgery. And a C Rastelli has got a lot of room to operate in there, but it may be, you obviously need double patch technique for the C Rastelli type of issues. And I obviously couldn't cover.
I have another question about the
An
outflow
hour.
tract.
But you know, how you fix the valve and the tension that you put on the valve now has brought us into other areas.
I have another question about the outflow tract.
Yes, the outflow tract.
Yes, sorry, because I
Question.
sometimes there is some case where you are not able to close completely.
Sasha,
Can you hear me? Yes, sorry.
what's your question?
Sometimes there is some case where you are not able to close completely. Can you hear me?
I can, yes.
Yes. You cannot close the cleft.
We have a little delay.
Yes. Is it?
Can you hear me?
Yes. Yes. You cannot close the cleft.
Yes, no, that's true.
Yes. Is it?
Especially if the papillary muscles are close
Yes.
together. And I think that that's something that, you know, we tell the surgeon about it. He's got a much better plan than being confronted with it, you know. I mean, before echocardiography, before angiography, well, not before angiography, but in the early days, I mean, angiography was the gold standard. I mean, there were lots of surprises when the surgeons opened the AV septal defect to look at it. Today, I think that when the surgeon goes into do the surgery, and especially if he's using three-dimensional images of the valve and the leak, you get a wonderful opportunity to look at those things, and you can use that in terms of how you're going to look at the valve when you repair it. I mean, whether you put an annuloplasty on, how much of the cleft that you suture, what kind of result you respond to. Now, surgeons are very tacit people. They don't talk much. But what I learned about surgery is that the surgeons know how good their repair is and what they're going to do. And many times that the repairs in these AV septal defects can be temporary, that they will try and repair the valve till they get the patient to be larger before they can do a more definitive procedure. They often don't tell us these things, and so we don't actually realize that the surgeons know exactly what the quality of their repair is and what the future of those particular patients might be after surgery.
There is a question by Miguel. Hi, Miguel. How are you?
Sasha?
Yes. Can you see the question?
Hello, Sasha. I can't hear you, Sasha.
Yes, there is a question in the chat box. There is a question by Miguel. Hi, Miguel.
Yeah, hi, Miguel. Arapa, yeah,
Yes.
Hello.
Can you see the question?
Yes, I see. Well, the indications obviously are from an echocardiographic point of view. Yeah, the patient is, having increasing ventilator settings or can't come off bypass, or, I mean, if you can't come off bypass, that's really an indication to go back. So I assume that he's saying the patient comes back to the intensive care unit, and then there's progressive cardiac failure, and from an echocardiographic point, the largest problem is going to be the association of AV regurgitation, particularly of the left AV valve. And so if you see a lot of AV valve regurgitation, I think you have to take the patient back and do something to the AV valve. And it is occasionally occurs that some of the sutures will de-yes. And so you really have to look at that and see as the vent settings rise and the patient starts to go into worse cardiac output, and the echocardiogram shows AV valve regurg, which is a usual problem, that you have to take that patient back and reattach to the valve, or even in the worst circumstances, put in an artificial valve. Do you agree? Sasha?
I fully agree. We have a problem. There is a delay.
I can't hear the answer.
Yes, I fully
I've
agree.
done that. Sasha?
Yes, I can hear you. I fully agree. We have a problem. There is a delay.
Yeah, right. It's terrible.
Yes. So
All
if
right.
you don't,
Well,
we
look, I
can,
think that if there are no
yes.
questions, I would thank
I fully agree.
all the participants for their
Yes,
attention,
I can
and
hear you.
I hope that this was useful for you, and that you will come on the 19th of December
So
to listen to
if you
VSDs.
don't, we can. Okay, Norman. See you in
So,
this.
Miguel has asked another question quickly. Miguel, I am not a believer in the nun procedure, but I think that the nun is not, that's the Australian technique of cobbling it up. I don't think that in
Okay, Norman.
yes.
See you in this.
Okay, let me just finish this question to Miguel. You know, usually that's the AV septal defect with the tetralogy. It's too big to even consider the nun procedure. I hope you could say something about that, Sasha.
Yes, I
Yeah,
think
terrible.
that,
Huh? Okay, we'll say goodbye.
yes.
There's even a
Thank you.
delay on the video today.
Very difficult.
Bye bye, Sasha.
Yes. Can you see me? Yes. I think that. Yes. Thank you.
Okay, bye bye.
Very